Hello and welcome to the Cleft Mama podcast. This is a supportive space for families navigating life with a baby diagnosed with a cleft lip and/or palate. Here we share real experiences, practical guidance, and conversations with parents and professionals to help you feel informed, supported, and less alone. I'm your host, Anja Paunel, and I'm excited to get started. Hello and welcome to the Cleft Mama podcast. So today I want to talk you through the cleft care pathway in the UK. And I actually was surprised myself that I hadn't actually had a previous episode on all the steps that you can expect to go through with you or your baby. So this is from receiving the diagnosis during pregnancy through the early surgeries and childhood appointments all the way into adulthood. And what I'm talking about here was also summarized in a publication, and this one is from 2023, so it is quite recent and reflects what happens nowadays. Before I begin though, it's important to say that every child's pathway will be slightly different. Just as we say, every cleft is different, so the pathway will also be different. So the exact treatment depends on the type of the cleft, the child's individual needs, and the approach that's used by the Cleft Center. So what I'm describing here is particularly relevant to a child with a complete unilateral cleft lip and palate, and there can obviously be some variations to that. But what's quite interesting is that the cleft care in the UK has changed significantly over the past few decades. So before 1998, there were 57 centres that were treating people with clefts across the UK. And at first that might sound, there were actually more centres that could be better because then you don't have to travel so far and there are just more resources. But the treatment there actually varied quite a lot between hospitals, and then outcomes were also varied. So they were not consistent between the different cleft centres, and it really made a difference which cleft center you were belonging to or which one you attended. So overall, the outcomes were not as good as they could have been. And this really came to the surface after there was a major national review, which was done by the Clinical Standards Advisory Group, so the CSAG, and they brought out a report and they recommended that the cleft care should be brought together under 18 up to 15 specialist multidisciplinary services. And bringing this all together into these smaller number of centers, this process is often called the centralization. So you may have heard of the centralization of cleft care in the UK, and that happened following that review. So after 1998, they created 9 specialist cleft services, and then each of these services can include one or more hospitals or cleft units. So now there are 17 cleft centers, but most importantly is that the care is really coordinated. So it's a specialist multidisciplinary team. And the idea really is that children do not receive isolated treatment, so just from one surgeon to fix the lip or another surgeon to fix the palate. Instead, it really is a coordinated team that includes the surgeons, also specialist nurses, speech and language therapists, orthodontists, dentists, audiologists, psychologists, and other professionals. So around 81% of babies with a cleft lip are diagnosed before birth, and a cleft lip, as we know, is one of the 11 conditions that are specifically looked for during the NHS anomaly scan. And that scan is usually carried out between 18 and 21 weeks of pregnancy. But as we also know, this routine scan produces a 2-dimensional image, and that means it's really extremely difficult to confirm whether the palate is also affected. So some centers may refer for further imaging, such as a 3D scan or even an MRI scan, to look at the palate in more detail, but for many parents, we don't know the full extent of the cleft until the baby is born. After the diagnosis was made antenatally, the cleft nurse should contact the family within 24 hours really. And this cleft nurse can then offer information, emotional support, and counseling, and will remain an important, if not the most important point of contact throughout the rest of the pregnancy and also after birth and beyond, usually for the first year of the child's life. And this early contact can be really incredibly valuable because the diagnosis often brings, well, a lot of immediate questions. And the cleft nurse is usually the person who begins helping families make sense of it all. After the baby is born, the cleft nurse will again visit the family within 24 hours. So this might be while they're still in hospital or after they've returned home. And one of the nurse's most important roles in those early days is to support feeding, because feeding is understandably one of the biggest concerns for the parents. And especially for babies where the cleft affects the palate, they would not be able to create pressure inside the mouth to generate suction from the breast or from a standard bottle. In this case, then, specialist bottles are commonly used. And some of these allow the parent to gently squeeze the bottle in time with the baby's attempts to suck and swallow. And normally parents would need some guidance on using them, which the cleft nurse will provide, because the squeezing should be coordinated with the baby's feeding rhythm. But as listeners of this podcast will know, there are also other feeding approaches that I've discussed elsewhere, and there is no single method that will suit every family. But this paper here was describing the standard UK pathway, which is using specialist bottles pretty much straight away. After a few months, then the parents will also generally be invited for the first outpatient appointment. And there, the parents and their baby will usually meet the cleft surgeon along with other members of the multidisciplinary team. So in terms of the surgeries for a child with a complete unilateral cleft lip and palate, the first operation in the UK is generally the lip repair, and that's carried out between 3 and 6 months of age. So generally in this operation, the hard palate may also be repaired, but the gap in the gum, so the alveolar cleft, is usually left until the child is older. And the thinking behind is that delaying this bone repair helps to protect the facial growth. Also, there are very opposing opinions on that, and I know surgery techniques elsewhere are closing that gap. But yeah, so that's not the case in the UK. So they close the lip and the hard palate, but leave the gap in the gum. The remaining palate, so the soft palate, is generally repaired between 9 and 13 months of age. And here the aim is not to simply close that visible gap. The surgery is also intended to create a functioning palate so that it can move properly during the speech. And this is so important because the soft palate needs to work with the back of the throat to completely shut that off, to control the airflow when the child speaks, to make certain sounds. So then after these 2 first surgeries, the years that are immediately following that palate repair are very important for the speech development. So the children will be closely monitored by the Cleft team, particularly by a specialist speech and language therapist. And there will be speech assessments around 18 months. And then again, it's 3 years. Also, the exact timing depends on how many words the child is actually using at that point, because the team needs to have a large enough speech sample to assess how clearly the sounds are being produced. So the aim for this child is obviously to develop functional speech, ideally before starting school. However, that means that approximately a third of the patients may need an additional surgery to improve the speech. The dental care also begins quite early, so as the baby teeth start to appear, families can have access to advice from a pediatric dentist, and the regular general dentist will also become important. So what's really crucial here is good oral hygiene, and that matters in those children born with a cleft even more than in any other children, because they have a higher risk of tooth decay. They're also more likely to have dental differences, meaning missing teeth, and the enamel may have also not formed normally. Then, just as another kind of check-in point, at around 5 years old, the child attends the first audit clinic. So there will be 4 audit clinics in total, and those are just basically assessing the child completely in terms of all the things that are able to do and not able to do. And this is really feeding back into the research of the CRANE database that I had described elsewhere to kind of compare how cleft care is, improving outcomes for children. So it's not necessarily to assess that single child, but it's more on a collective cohort where they assess children that are being treated in the UK at 5 years, 10 years, 15 years, 20 years. So at this first audit, there is a larger multidisciplinary review, which involves areas such as dentistry, orthodontics, hearing, psychology, clinical photography, and speech and language therapy. So the team looks then for any emerging concerns, but as I said, it also collects standard information for the national CRANE database, which helps assess and improve cleft care across the country. Then, as the permanent teeth or the adult teeth are beginning to come through, now the attention shifts again towards that gap in the gum that I mentioned that was left in the beginning. So children with a complete cleft lip and palate are then assessed by a cleft surgeon again, an orthodontist and dentist, and they are beginning to plan in alveolar bone graft, which is shortened to ABG. You may have heard of ABG before, which is a bone graft to fill that gap in the gum. So here they conduct x-rays first to assess the gap in the gum, see also how the permanent teeth are developing and whether there are any extra teeth that first may need to be removed. The team will also decide whether any orthodontic treatment is needed before the surgery. So that would be braces, for example, and that could be needed to widen the upper jaw first to create enough access to the cleft area. And then when the bone graft is conducted, this bone graft helps to stabilize the front of the upper jaw and to provide bone for the permanent teeth to come through, but also for future orthodontic treatment. So for any braces, for example, to actually have something to attach to. So there is no strict timing around that. In the UK, the timing is guided by the dental development. So the aim is to usually complete the graft before the permanent canine tooth erupts, so before the adult canine teeth comes through. Then again, the second major audit clinic takes place when the child is around 10. And by this stage, the bone graft should then have normally been completed. Some cleft centers also use questionnaires at that point that allow children and families to report their own experiences of their appearance, their health, and their quality of life. And this helps make sure that the outcomes are not judged only through scans, photography, or clinical measures, but also just to hear from the patients themselves. So they're not really using the questionnaires at the 5-year audit, or at least not for children, because at that point, they may not be able to read and understand and give those answers. But at 10 years, they're trying to get to hear from the children themselves as well. And as we're going further on into adolescence, most people with a cleft will require some form of orthodontic treatment. And this may include helping the permanent teeth to actually come through into the area where the bone graft was placed. And some children may also need restorative dental treatment to replace the missing teeth or reshape the teeth that have developed differently. For example, a canine tooth may be reshaped to look more like a missing lateral incisor. So it's basically changing the shape of the tooth. Then when the child is 15, there will be the third major audit clinic. And at this stage, the team is looking for anything that may need attention at this point, because then the growth of the face is nearly completed at that point. So this could then include concerns about the function or the appearance of the lip or the nose, or whether any jaw surgery might be needed. So some people with a unilateral cleft lip and palate develop a difference in the relationship between the upper and the lower jaw. So that means the upper jaw might not grow forwards as much as expected. And this can be related both to the cleft itself or to the effects of surgery and the scarring during the growth after the surgery. So if that is the case, so basically there's a underbite. If it's only mild, that might be managed with orthodontics alone. But in more pronounced cases, there might also be surgery to move the upper jaw forwards or occasionally to reposition both the jaws. But in this case, they involve a psychologist to support those young people at that point, as they consider those quite difficult decisions of whether to undergo quite a big surgery. Then at the age of around 20, there will be the final audit clinic. And if there are no ongoing problems that need active treatment, the young person then can be discharged from the cleft services. But discharge does not mean the door is permanently closed. So adults born with a cleft can return to a cleft multidisciplinary team later if they have new concerns. For example, they may need specialist dental treatment if the earlier restorations begin to fail, or they may want genetic counseling when they are starting to consider having children of their own. Also, so this is what is being said in that paper, and that should be the pathway we know of adults struggling to get actually dental support once they reached the age of being over 18. And then the dentistry isn't free for them anymore, but it should be because they are cleft patients. But yeah, that's definitely something I want to bring up on another podcast. I want to mention again, so I said already that we have those 4 audits and they're feeding into the Crane database. And one important part of the work of the Crane database is to monitor how individual cleft centers perform. So they're using key measures there, such as whether the palate repair is completed by 13 months. And they're comparing all these measures with national benchmarks. And if any results for a center fall noticeably below the national average, then this triggers an alert or an alarm. And the process of investigation and quality improvement is then started. So this is really also to monitor that the same standards are applied across all of the UK. And we can be confident that our cleft center works just as good as another cleft center. So it's not like a postcode lottery, which maybe we heard of in different situations. The same system can also identify any centers that are achieving particularly strong results. And then those would be asked to share what leads to their success, to share that with the other teams so they can learn from that as well. So hearing about this whole pathway can definitely feel a little overwhelming, but we have to remember this is stretching over a long period of time. So what I've described is from pregnancy all the way into adulthood when the child is 20 years old. So most of the contact and most of the surgeries happen in the earlier years, particularly in the first year. But as the children grow, routine appointments become much less frequent, and unless there's something that needs closer monitoring or treatment. But it's, just hearing that, it's also not a prediction of what exactly your child will need. So some children may need fewer interventions and some need more support, but just in one specific area. So every child is an individual, so we can only use that as a guide. But I hope this overview has helped you understand what to expect from the cleft care in the UK and what the major stages may look like. So we know that knowledge does not change the diagnosis, but it can make the pathway feel a bit more predictable and can help you be more prepared of what is coming and what's ahead of you. So thank you for listening, and I'll speak to you again next time. Bye. Thank you for listening to the Cleft Mama podcast. I hope you get a ton of value out of our time together. You're not alone in this journey. And remember, You're doing an amazing job. If this episode helped you, please follow and share it with another parent who might benefit from it. See you next time.